Hi, everybody. I'm Mike Putman from the Medical College of Wisconsin. And today I'm excited to tell you about a 43-year-old patient with a recent diagnosis of rheumatoid arthritis. Now, my patient had initially been diagnosed 5 months prior with an inflammatory polyarthritis. She tested negative for rheumatoid factor and a CCP, but her sedimentation rate and CRP had both been elevated. And she initiated therapy with hydroxychloroquine and methotrexate with an outside rheumatologist. And, when she came to me, when I first met her, she said that she'd overall responded somewhat poorly to therapy. Now, over the past few weeks, she had experienced a red eye that was initially diagnosed by an urgent care doctor as conjunctivitis. She did not respond very well to eye drops and instead experienced progressive pain, as well as some new photophobia, trouble going outside in the light, and some persistent tearing. Now, after she came to an optometrist, she was sent to the emergency room because they thought she could have scleritis, which they said might be due to rheumatoid arthritis, which, we all think that's pretty plausible, right? Now, when we saw her, we actually took a look at her eye, and it was not episcleritis, as one of the urgent cares had originally considered, but was actually quite concerning. So she had an enlarged and injected red vessels all around her eye that was consistent with scleritis to me. But then she also had this thinning and blue discoloration around the iris that even I, as a non-ophthalmologist, could appreciate was abnormal and certainly concerning. So we consulted a proper eye doctor who promptly diagnosed her with bilateral scleritis, limbal thinning, and peripheral ulcerative keratitis, or PUK. Now, this leads to my first take-home point from today, which is to take eye disease and rheumatoid arthritis very seriously. PUK is one of the more feared complications of rheumatoid arthritis eye disease, and when left untreated, can actually result in perforation and ultimately in blindness. Now, this requires an urgent therapy, and we started IV prednisolone. Interestingly, steroid drops are somewhat controversial given the potential for further thinning, and I tend to defer that to the eye doctors. Now, you'd think that this is a nice, tidy conclusion to our case, but when our patient was admitted to the hospital, she was also noted to have acute kidney injury with a creatinine of 2.3. Now, after fluid resuscitation, this did not improve as we had hoped that it would. And my second take-home point for today is to avoid anchoring on a diagnosis of seronegative rheumatoid arthritis. I mean, look, we all know seronegative rheumatoid arthritis is very much a real thing. About a third of patients with RA will be seronegative, as our patient was. Her initial diagnosis was honestly reasonable, but it certainly did not explain the kidney injury. And her lackluster response to methotrexate gave me pause. So what else causes PUK? Whenever you have sort of a what else could this be question, I like to tell my trainees to just sink their teeth into something. What about this case is odd? And PUK certainly stood out. So rheumatoid arthritis is the most common cause of PUK, but granulomatosis with polyangiitis and systemic lupus erythematosus both account for reasonably large fractions of cases. But a third of cases of PUK can be not associated with systemic illness. For anyone who loves medical eponyms, this is called Morin's ulcer. But I don't like eponyms. And when a patient already has inflammatory polyarthritis, I certainly do not think that this is going to be an isolated case. So given some suspicions for alternative diagnosis, we sent ANCA testing and consulted nephrology. The ANCAs returned with a high titer of a PR3 antibody, and nephrology was sufficiently concerned about her active urinary sediment that they performed a kidney biopsy. This ultimately found pauciimmune glomerulonephritis. This takes me to my third take-home point, which is that ANCA-associated vasculitis presents with inflammatory arthritis in nearly half of cases. That certainly does not mean that all patients with inflammatory arthritis need to undergo ANCA testing. You would get a lot of false positives if you did that, and it would not be pleasant. But I do perform a review of systems for ANCA-associated vasculitis in all patients with inflammatory arthritis. And then patients who have suggestive features such as unexplained renal disease, aggressive sinonasal disease, purpuric rashes, or wrist and foot drop should receive ANCA testing in addition to whatever your workup is for the inflammatory arthritis by itself. So take-home points, take eye disease and rheumatoid arthritis seriously. It can be very dangerous. In this case, one of the take-home points was that you should avoid anchoring on a diagnosis of seronegative rheumatoid arthritis because sometimes you will actually find another disease. And my last one is that ANCA-associated vasculitis presents with inflammatory arthritis more often than people think. So always keep that in mind. Thanks so much for having me. I hope you enjoyed this case.